The source of this pathogen is highly likely a zoonotic spillover, meaning the virus jumped from an intermediary animal host directly into human populations. While the outbreak was officially recognized in Wuhan, China in December 2019, the timeline extends further back. Epidemiological tracking of the first known human cases suggests the virus was present as early as mid-November. Within weeks, a localized cluster rapidly escalated. The virus crossed international borders, leading to a pandemic affecting countries across the globe. Pathogens that cause severe, debilitating symptoms immediately upon infection typically limit their own spread. A host who is too sick to move cannot effectively transport the virus to new locations, causing the outbreak to burn out locally. The immense geographic scale of this pandemic indicates a different mechanism. To traverse the globe this efficiently, the virus must operate covertly, bypassing the host's physical warning systems during the critical early stages of infection. This momentum is powered by a pre-symptomatic engine, a hidden biological timeline that separates the act of transmission from the onset of clinical illness. This chart shows the primary clinical manifestations used to identify the disease once it takes hold. Fever dominates the clinical profile, presenting in 88% of cases. This is followed by a persistent cough at 68%. The physical mechanism of transmission relies on small droplets from the nose or mouth, expelled when an infected person breathes or speaks. These expulsions are fueled by active viral replication, heavily concentrated in the upper respiratory tract and lungs. This graph tracks viral shedding, how much active virus a patient emits over time. The critical anomaly is at day 0. The absolute peak of shedding occurs just before symptoms begin. A patient reaches maximum infectivity days before a cough prompts them to isolate. This massive pre-symptomatic shedding peak is the true biological engine driving the rapid global spread. To understand how this individual timeline scales, we map it to macro-level epidemiological metrics. The basic reproduction number, or R0, represents the average number of people infected by a single host in a susceptible population. The estimated R0 for COVID-19 sits between 2 and 4. Next is the clinical onset interval, which tracks the time between the appearance of symptoms in successive cases along a chain of transmission. In most studies, this interval averages just 4 to 5 days. The ultimate stakes of this rapid transmission are defined by the global crude case fatality ratio, which is approximately 7%. Combining a high R0 with a short onset interval and high pre-symptomatic shedding mathematically guarantees exponential spread. Aggravating environmental situations, such as dense urban areas or mass gatherings, exploit the specific transmission window by providing the necessary close contact. These environments are the setting for super-spreading events, where a single pre-symptomatic person transmits the virus to an unusually large number of people. Population-level exponential growth is simply the individual pre-symptomatic shedding curve weaponized by human density. This graph of viral shedding reveals why specific public health interventions are required. Symptom-based screening alone fails. Waiting for an 88% probability of fever means testing patients on the downward slope, entirely missing the peak transmission window. Isolation is an epidemiological measure with a very specific goal. Isolation targets the right side of the shedding curve. It is the separation of people who are already ill and symptomatic from the broader population. Quarantine is a distinctly different strategy. It restricts the activities of individuals who are not ill but may have been exposed. Quarantine operates strictly on the left side of the curve. It is the primary method used to neutralize the pre-symptomatic phase. Contact tracing executes this strategy by identifying these outwardly healthy, exposed individuals in order to separate them before they reach their shedding peak. Diagnostics support this, but with distinct parameters. Antigen tests detect viral antigens for acute diagnosis, whereas antibody tests are not useful early on because the IgG and IgM response is undetectable during the crucial first week. To halt transmission, public health interventions must operate strictly on the virus's covert timeline, bypassing the host's delayed biological alarms entirely.